All right, so Burke Partridge, please. Dr. Ravagan, Anand's already here, and Charles Anthony, please. And Burke's right here. Yep. He's right here.
You can just introduce me, I'll start.
Absolutely. All right. Just do it from here. Okay. All right, I think we're ready to start the section. This is the session on MHealth. It's indeed my pleasure and honor to introduce the first speaker and co-chair of this section, Professor Ganapathy. I had an opportunity to meet him at the MHealth Summit in D.C. in November that the FNIH ran, and I was very impressed by his scope of knowledge of not only global health, but certainly MHealth. So I'll turn it over to Dr. Ganapathy.
Good morning, everybody. Dr. Campbell, if I exceed 1,200 seconds, please switch off the power.
I have a whip.
Thank you. Can I have the lights off? I'm bright enough.
The mic. It's not coming on that sheet. It's not coming on the projector.
Can somebody switch on?
Hand mic or not?
We were using a hand mic. I don't think that podium one works. There it goes.
Is there somebody in the audio visual? Okay. Ask him to switch on.
It's not coming on any laptop or any personal software.
It was Lars Lexel, the inventor of the Gamma knife, which at that point of time was the most sophisticated equipment in the world. He said a fool with a tool is still a fool. And I think here technology is, though we are all technology enabled and interested in technology is... I thought as much. The plug had not been switched on to the main power source. Good. First slide. Okay. In the next 12 minutes, I'll try to give a bird's eye view of what I personally am absolutely convinced that we are going to have a reinvention of healthcare using mobile phones as an enabler. As I talk to you, 50 phones are being sold every second in India, 13 million a month, and we have already reached a staggering figure of 752 million mobile phones with an urban penetration of more than 20%. Ladies and gentlemen, the need is there. Healthcare spend is increasing unsustainably. In the United States, it is expected that 37% of the gross national product in the year 2050, which is not too far from now, will be devoted to healthcare. And what is more interesting is, statistics have shown that lack of access to basic health care staggeringly increases the mortality rate. And you can see in Africa how the mortality is 400 per thousand because in areas where basic health care is not available. The demand is equally strong. Let us look at the significant interest in MHealth products. McKinsey carried out a study, and interestingly you find on the right hand column India, 68%, a huge number of people interviewed wanted the services of a phone doctor, and they were even to take drug delivery information and even have drugs delivered to them with the use of a mobile phone. A health watch, a sensor in your watch which will measure your blood sugar. In India, a so-called emerging economy, a developing country, 59% said if that facility was available, they would use it. And again, if you look at the technology which is available, already available, you can see smartphones. It is predicted that in the next few years, 30% of all mobile phones will actually be replaced by what today is called a smartphone. And even with existing technologies, you will be able to provide health care. Today we have all sorts of medical devices. Now Anand Iyer will be elaborating on some of them. And again, software which has been used for triage algorithms, flowcharts, which direct computer prompts, which direct a non-medical person how to go about it. These have been in existence for more than 10 years. Again, business models, we are not at liberty to divulge the exact company, but I understand that business models also show that this could be a profitable venture. No wonder, as McKinsey again said, that you have pilots everywhere all around the world. As one speaker said in a previous conference, there are more pilots in mobile health than there are in the United States Air Force. What is preventing these pilots from becoming, these proof of concept validation from becoming an integral part of the healthcare delivery system? Can the MHealth be used as a vehicle to transform healthcare? As you can see in this slide, it is not the technology alone. Smartphones alone are not enough. You require an orchestration of players, information, workflow, and so on. Now, in this slide you see, borrowed from Accenture, that MHealth devices are not top of the mind even to tech-savvy consumers. People who use desktop computers, people who use e-books like Kindle or various other things, even when such highly tech-savvy people were asked about MHealth, they were quite ignorant about it. A few days ago, we carried out a study at the IIT Madras, the Indian Institute of Technology, the cream of the cream of the cream of Indian population perhaps, and the results are only now being analyzed. But again, the majority of people, almost 80% of people in the IIT campus Madras had no idea about the health applications which a mobile phone could be done. I think this is very, very important. Now, how can MHealth help? We can use it in various ways. We can use it for remote doctor services. We can use it for drug authentication and compliance. Yesterday we heard how drugs could, instead of just being a friend, it could be a foe, and even 10% of deaths iatrogenic drugs could actually be drug enabled courtesy of the healthcare profession. A mobile phone could go a long way in neutralizing this. Telediagnostics. Gone are the days, or going are the days, when you need to physically tie a BP cuff around a patient and check his blood pressure. Remote health monitoring, assisted care support. This morning we had a beautiful session on the necessity for electronic and mobile healthcare records. But instead of accessing it on your computer, on your desktop, on your laptop, why can't you access it on your smartphone, which is always available with you? The mobile phone can be used as a peripheral diagnostic device. Today, the FDA has approved several peripheral medical devices, including ultrasound equipment, which fits into your pocket. And believe me, I have seen some of them. The quality is absolutely fantastic. And this can, through Bluetooth-enabled devices, connect to a smartphone and send the data onto wherever you want it. What India lacks, what most developing country lacks, is not technology, not even bandwidth, which eventually will be solved, but lack of human care, lack of human resources, lack of ultrasonologists to interpret these shadows which you can see on your mobile phone. Prevention and wellness. I like previous speakers' beautiful description of prevent the preventable, cure the curable, and again, mobile phones can play a major role. The ordinary BlackBerry which you have, and you can, or any phone which you have today, we have the Hippocrates pill, we have a glucometer, Bluetooth enabled, which can be added. You can look at a ECG and so on. Most peripheral medical devices today are available in a mobile phone. I foresee that within the next 5 years, the smartphone could literally be a handheld hospital. Unfortunately, India has the #1 record in the whole world. The maximum number of blind people living are in India. They are technically blind, legally blind, meaning they are not able to see. This is due most often to ordinary refractive errors. We just don't have optometrists. We don't have ophthalmologists around the length and breadth of rural India who can prescribe glasses. And the MIT, again led by a group of Indians, have now making this commercial how a mobile phone a software can be loaded on a mobile phone, and by simply playing on some lines to make it focus one on top of the other, you don't need to be even literate. The mobile phone would tell you whether you have astigmatism and would even say 2.25 plus, minus 1.75 and so on. And again, as you can see here, we have sensors and many of the routine peripheral medical devices which need to be used can be incorporated in the mobile phone of the future. One of the fascinating things which I listened to at Barcelona at the MHealth conference was what was called the Internet of Things. Again, the basic motive among all the mobile healthcare providers, or rather the mobile network providers, is they foresee that in the next 5 years, there will not be any more potential for growth. After all, you can sell 2 mobile phones to one person, you can sell 3 mobile phones, but after 25 years, there will be no human on the planet left who does not have a phone which is used just for communication. Why should we, let's think out of the box. Why should we think that a mobile phone is only to communicate from a human being to another human being? It could be through SMS, it could be through MMS, but again, at some stage, human intervention is needed. What if you have an Internet of Things? What if one object communicates with another object? And then there's absolutely no limit to the potential. We literally have hundreds of billions from smart refrigerators, from smart pills. The communication will go directly to the pharmacy. You don't have to come into the picture at all. And this, ladies and gentlemen, is what is going to happen, the Internet of Things, where human intervention may not be required at all. Most people feel that they are pretty good at forecasting based on previous trends. And here, a very reputed organization, The Economist Intelligence Unit, predicted that in the year 2012, India's mobile tele-density would be 47%. They were totally off the mark. Today it is 63%, or rather it was 63% last year. Maybe it is nearing 67 or 68%. I always think that India is a paradox. On the one hand, we don't have drinking water for hundreds of thousands of villages. But again, we can plant a flag on the moon, totally indigenous. M-banking, M-commerce, M-entertainment. There were literally millions of people watching India win the World Cup on a mobile phone. Today you can order a pizza, you can do M-banking. Urban India, there are 60 million Indians who already have subscribed to M-banking. The Reserve Bank of India is almost every day, every week, at least once a week, giving permission to a new bank to start mobile banking. MHealth in India, ladies and gentlemen, is conspicuous by its absence. Why can't we use the technology which all of us are using for M-entertainment, M-commerce, M-governance? Yesterday evening in the government initiative section, we saw how the government of India has already looked at e-governance, and from e-governance they are branching into M-governance, because that is the future. India will never ever be able to have enough broadband penetration, enough personal computers, enough laptops, but we already have mobile phones. Now if you look at some relevant statistics, you see at the moment we have only 22 million internet subscribers, wired subscribers. But the Airtels and Aircels, the Tatas of India predict that in the next 5 years, access to the internet through wireless technology is going to be at least 5 times this. Again, the government of India has already started 100,000 e-enabled community service villages which offer all that is required for the average citizen. But again, unfortunately, health is conspicuous by its absence. Though we have the infrastructure, we just need to ride on it. 60% of rural India already have access to television. Why can't we make use of the cable network to provide health care? The pressure to innovate new approaches to tackle acute and emerging epidemiological and other health challenges, the increased IT adoption by healthcare providers. 3 years ago, we would never have thought it possible to get 500 people in India assembled for a 2-day conference dealing exclusively with healthcare information technology. So this is the real India, the India which is changing fast. The rural-urban healthcare divide. India has outstanding centers of excellence. We no longer compare ourselves with Johns Hopkins and Mayo Clinic. Johns Hopkins compares ourselves with the All India Institute of Medical Sciences in India. But then we just have about 20 or 25 of them. The mobile phone can be a medium to bridge the gap, the tremendous gap which exists between the urban and the rural health divide. Education and awareness. I am absolutely convinced that knowledge management is crucial, that empowering a patient with knowledge will have tremendous impact on the health outcome, much more than buying 3 Tesla MRIs or intraoperative neuro navigation. Today, the patient comes to me and asks me why I am not doing that particular procedure. Do I know about drug-drug interaction? The power of information medicine. As Muir Gray very eloquently put it yesterday, this decade is the decade of the patient and not the decade of the doctor. All this can be enabled using the ubiquitous, simple, ordinary mobile phone. Again, we talk about not only its vast coverage, it's user-friendly, it's less power-dependent, the low cost, and of course it's very private, it's very personal, it's inside my pocket. I don't have to, even if I use a laptop or a computer, there may be other people peering down my shoulders. So I think every one of them is important. We personally got interested in mobile health, and I must place on record our thanks to Ericsson, who in August 2007 asked us if we would do what then was the first proof of concept validation, and we successfully carried out a study of 280 patients. Today it looks rather simple and rather silly, but even 4 years ago it was a tremendous achievement. Entirely through wireless technology, we were able to transfer blood pressure, 12 ECGs, auscultation, teleauscultation, and the patient and doctor satisfaction was pretty good. A couple of months ago, we have embarked, I think Charles Anthony will be elaborating on this in detail, and I personally think this is the way to go, where we have a phone doctor. The phone doctor need not actually be a medical doctor, but he would certainly be, he will have access to all the information, authenticated, validated information in the world. Again, your personal health record. How relatively simple it is to store this data on your phone. And again, H&G, I must place on record, they have been doing a lot of work on this, and the day is not far off when we will be using totally indigenous components for this. So what are the challenges? It's very easy for me to stand before you and give you a lecture for a couple of hours, but it's extremely difficult to translate this into ground reality. We have no policy framework, we have no regulations, we don't know what are the legal issues, and of course interoperability. We don't know whether the operating systems will be equally suitable for different types of machines. Ladies and gentlemen, as I mentioned yesterday, I belong to the BC era. Today, the expectations have become an all-time high. Just look at this advertisement which comes in the newspaper and the TV. You can't even wait to switch on the air conditioner after you go to your house. Onida is marketing a product which says SMS gone, AC on. You switch on the SMS, so by the time you get into the room, the air conditioner is already on. This is the emerging India. This is the India of the future. And if you have the technology to send an SMS to switch on your air conditioner, why can't we use this technology to send an SMS to a healthcare provider, and we can put in place a system whereby 24/7 appropriate, cost-based, need-effective technology is used to provide you with healthcare. Ladies and gentlemen, this is not impossible. Improbable, yes. Impossible, no. But what is the real challenge? The real challenge is, for 6,000 years, when the formal so-called modern medicine developed, it has been a human face-to-face encounter. Even today, it's going to be extremely difficult. And as was mentioned yesterday again, we must never ever forget that technology is a means to achieve an end and not an end by itself. And you have heard of Wi-Fi, you have heard of WiMAX. I have coined a term which I think is very important, YFM. What is in it for me? WIIFM. At the end of the day, unless every stakeholder, there is something in it for him. It need not be incentivization, need not be a monetary compensation, but there has to be something. Let us not be hypocrites. Let us not say we are doing this for sake of suffering humanity, to wipe the tears from everybody. That's why it's a noble profession. That's why I became a doctor. All this may have been true in the 18th century, but in the 21st century, what's in it for me? And I think if you answer this question, what's in it for me, mobile health will really take off. You have not yet switched off the power, so I think I'm still in time. Thank you very much for giving me this opportunity.
All right, so our next speaker is Brooke Partridge, CEO of Vital Wave Consulting from Palo Alto, California. Had an opportunity to talk to her a little bit last night. I know she's been involved in MHealth for a long time, certainly at the nascence of the MHealth Alliance associated with the UN Foundation, and continues to do so. So the title of the talk is Lessons Learned from Other M Services. Brooke?
Thank you, Scott.
Can you use this to change the presentation?
Okay, great. Thank you. Good morning. That was a fantastic opening session, because it just was, but also it helped introduce a lot of the concepts that we'll talk about in my session. So thank you very much, Dr. Ganapathy. Pilot paralysis, siloed implementations, recreating the wheel. These are all terms that have been used for years to describe the state of the field of MHealth. And they are symptoms of the struggles for scaling MHealth implementations. Vital Wave Consulting is a specialized firm in developing scalable, sustainable technology solutions specifically for developing countries. And a large portion of our work today is focused on M services, including a lot of focus on MHealth. The challenges to MHealth are shared by a lot of M services. And so the list you see here on the slide is actually a taxonomy of different forms of M services. And just to describe them for a minute to make sure we're all on the same page. MHealth, for instance, we saw some great examples. In terms of definition, it's the use of mobile technology to improve the delivery of healthcare or to improve the management of healthcare policy. M-Finance is the ability to transfer money from one person to another, from one person to an organization or a company. It's for savings. It's for making payments. M-Activism is something we've been hearing a lot about in the news recently in Northern Africa and the Middle East, as people have been using mobile technology to galvanize social and political activities. And M-Identity is one to pay a lot of attention to, because it's important for all forms of M-service, as more sophisticated forms of interaction require security and the ability to really identify who you're speaking to or who you're communicating with. Each of these areas of M-service have their own community of professionals that are focused on developing and creating applications and solutions that will address their particular vertical market. But one way to help all of these fields of M-service overcome the challenges of scale is to have an orthogonal view to M-services. And we have found this to be very important in helping clients and organizations think about how to overcome scale. These areas of M-service generally share a common set of application types. We saw them actually in some of the slides that Dr. Ganapathy shared. When you think about for instance, education, if you look across the top, MHealth allows for the exchange, for campaigning, for providing information to wide sets of individuals around healthcare practices. At the same time, there might be the opportunity for M-commerce to send out promotions, so that's education or campaigns. There's also transactions, and just about every form of M-service has transactions involved, whether it's the exchange of goods or the exchange of information, money transfer, communication between patient and caregiver, between sellers and buyers of products. So this is an alternative perspective for thinking about and managing M-services that we see will help overcome the challenges to scale that are being experienced across all the different fields and areas. Some other critical success factors for M services. First of all, designing for scale. There's often a lot of enthusiasm, especially in the areas where we focus, which is in the less developed areas of the world. There is enthusiasm to use mobile services to address essential development issues, whether it's providing money transfer or it's healthcare. And so there's an incentive for speed to market. That, however, tends to avoid or skip over the process of planning for scale. And one of the reasons that we find that the field of MHealth is stuck in pilot paralysis is because there wasn't time to plan for scale in the first place. We talk a lot about going slow to go fast. Putting that effort in the beginning helps allow for scale later on. The next one, matching solution to needs and situation, may sound pretty obvious, but it's often approached more in terms of here's a technology that's interesting, let's apply it, as opposed to looking at the multidimensional areas or the multidimensional assessment that should be done before an MHealth strategy is set. For instance, looking at the physical infrastructure as well as the healthcare system in addition to the needs of the actual patients. And this is an approach that we've seen work well in cases, for instance, of M-Pesa in Kenya. If most of you, I'm sure, are familiar with it. It's a wildly successful money transfer system that found a way to take into account infrastructure and the actual market needs to apply on a very mass basis. But we find a lot of the pilots don't actually take the time to look at all of those levels of analysis. Designing with a larger digital ecosystem in mind, every form of M-service is actually a subset of E-service. M-health is a subset of E-health. M-finance is a subset of E-finance. And so being able to plug into the back-end larger systems is essential for scale and for large-scale deployment. Optimizing the underlying processes. There are always legacy systems involved, whether it's on the E side or there are other processes in place that need to be taken into account when M services are implemented, another critical success factor. And then embracing standards. Creating and embracing standards helps to avoid undue limitations to scaling or to working across different systems as programs actually scale to national or even international levels. So these are some of the critical success factors we've seen from different forms of M services around the world. And with the short time that we have, I wanted to share some of these concepts and then open it up later on for specific questions that the audience might have.
Thank you very much for that. The next speaker will be Patricia and Mikhail. Unfortunately, she couldn't make it at the last minute, and we have a video presentation. Patricia Mikhail is an absolute authority on MHealth. She is a Director of Strategic Applications of Mobile Technology, and we really miss her physical presence here. But then, as you say, today distance is meaningless. Geography, in fact, has become history. So we'll now have a recorded video presentation from Patricia.
My name is Patricia Michelle. I am the Director of the Strategic Applications Mobile Technology for Public Health and Development here at University.
Can we go on to the next speaker while this is being sorted out? Or Will it take some time? Okay, can we go on to the next speaker because in the interest of time. It's my privilege now to request Dr. Srinivas Raghavan, who is going to present a paper on behalf of Dr. Mehran Mehrigani, again who was unable to come at the last minute. Dr. Mehrigani is the Director School of Engineering, K School of Engineering in San Diego, and I'm told, if I'm right, he's probably the first group in the world to start an MD course on wireless medicine. I mean, I could never ever have dreamt that there would be a course on wireless medicine offering an MD degree, and Dr. Mehran sends his apologies for not being able to come, but his co-worker Srinivas Raghavan will be presenting this case. Srinivas? I understand the video problem has been sorted out. Can we now have Patricia on stage, please?
Good morning. My name is Patricia Michelle. I am the Director of Strategic Application of Mobile Technology for Public Health and Development here at Earth Institute at Columbia University. And it is my great pleasure to join you, however virtually, in India for the second international conference on transforming healthcare with IT. Unfortunately, I'm unable to be with you physically, but hope that these remarks will find you all doing well and enjoying the conference. Before I begin, I would really just like to extend my gratitude to Dr. Ganapathy, first of all, for being an amazing colleague in this space, but for inviting me to participate in this occasion. And then also to my fellow panelists who I really would have enjoyed the in-person interaction and face-to-face dialogue in this session, and wish you all the best in the proceedings. So today, really what I want to talk with you about is to sort of share a little bit about my experience in working in mobile health and some of the trends that have emerged over the course of the past 10 years. And so I began my work in mobile health in 1999 when I applied for my PhD to the London School of Hygiene to look at the natural progression of mobile phone use for public health in low and middle income countries. And at that point I did my field work in Egypt and Bangladesh, really looking at sort of how people in the general public as well as within the health system were already starting to use mobile technology to support their activities, to access health service, to mobilize transportation, for disease surveillance, and for what is increasingly becoming known as mobile telemedicine. And so it is, since that time, many things have changed. We are now in 2011. There is a great deal of interest and buzz and hype around MHealth and the transformative power that it has and can have within health systems. And sort of looking a little bit, I'd like to sort of take some time to look at how we might sort of rewrite the rules of engagement given where we are now in the current environment. So when I began my work in this area, the penetration rates of mobile phones in most low and middle income countries was restricted to urban areas. It was about 2 to 5% of the population. We are now looking at a point in time where more than half of the world's population has access to a mobile phone. And so this significantly changes what we are able to do with mobile technology to really try to improve the health outcomes, particularly around the Millennium Development Goals for health, looking at things like maternal health, the health of children under 5, and then addressing the diseases of poverty, as well as increasingly looking at non-communicable diseases in low and middle income countries. And so, sort of from the beginning, a lot of the initial mobile health work really came out of the interest of computer science to look at how mobile technology and different types of applications could be used to support a range of sectors. So people were doing work on agriculture, they were looking at how they could apply mobile technology to health, to finance, etc. And a lot of the early research and studies in this area really focused on feasibility, on usability, and the user experience. Now what we're starting to see is a real interest from the health sector. Many ministries of health have now highlighted mobile health as well as telemedicine as key strategies for how they would like to address the health priorities within their countries. And so there's this pull now happening and a shift to move the technology out of computer science and engineering and really to mainstream it into the health system. And so what does this mean? For the past, I would say, 4 or 5 years, we've had a lot of pilots, very small scale testing of mobile phone applications to address things like maternal health, immunization coverage, tuberculosis. And now what we're starting to see is sort of a movement towards larger scale implementation, as well as a move from sort of single point, single focus applications to really looking at how mobile technology can be used as a tool for overarching health system strengthening. And so what this means in many ways, and some of the lessons that we're learning along the way, is that you can't simply look at one particular issue, because in the end, whether it's your community health worker, your nurse working in a clinic, they're dealing with a multitude of issues all at the same time. So one application that simply deals with tuberculosis can actually be quite disruptive within the health system unless you're taking a much more comprehensive and holistic look at the way that the technology is being integrated and can be used. And so if you look at it from, say, beginning with the end user, whether it is a family, living in a remote village, an individual in an urban area, a healthcare worker at a clinic, or at a district hospital, we now need to really start to think about what are the socio-cultural issues that each of those people needs to sort of consider as they begin to leverage technology to support their work, and for the people that are implementing these types of systems to really begin to take these issues into consideration so that we move from knowing that a piece of technology works and or generates the outputs or outcomes that we want it to generate to actual meaningful use, real appreciation for the users of the technology and the beneficiaries, and then looking at how that in turn then generates the types of health outcomes and improved quality of care that we all are striving for people. If you go up sort of one layer more towards the management side and the administrative side, many of the mobile phone applications that are being used and leveraged are now reaching into areas that were never reachable before. And so there's a great opportunity for task shifting. Many countries have huge shortfall in their human resources for health. And so how do we empower individuals like community health workers, or in India, the ASHAs, to really be able to serve the communities in which they're working in a more effective manner? And how can we, extend the reach of services to populations that, prior to the introduction of mobile technology were unreachable and had limited access to the different types of services that they would need in order to maintain either, good well-being and prevention of disease, and or for the diagnosis and treatment of, a broad range of conditions that are now, increasingly shifting from infectious diseases, as well as looking at things like chronic illnesses, diabetes, hypertension, etc. And so at the administrative and management level, what are the types of tools that are able to sort of provide the types of reach that they need, as well as support the health workers at the point of care when and where they need the support. Within one of the projects that I'm working on, the Millennium Villages project, some of the ways in which we have addressed some of these issues is to introduce things like toll-free emergency lines in remote villages where they didn't exist before, or to create things like close user groups so that health workers can communicate with each other for free. They can consult with clinicians at a higher level when and where they need it. In the last couple of years, we have started to introduce some mobile phone-based applications to support their work, and so we're seeing this shift more towards point-of-care support tools with things like Child Count Plus, one of the applications that we have to do remote patient monitoring, as well as early detection and treatment for danger signs at the community level. And what we're starting to see now too is that the data that's being generated by a lot of these real-time monitoring systems are the types of data that we need for disease surveillance, for doing research into health outcomes and sort of tracking trends and changes over time. We can look at things like immunization coverage and how well we are able to sort of reach different populations. And so what's happening now, in essence, is that the rules of engagement are really, really changing. So we need to move away from isolated implementations, single focus, single point of care type implementations. We need to move the research out of computer science and increasingly into looking at health outcomes and cost benefits. As one of my very dear colleagues in this area, Peter Benjamin likes to say, counting SMS messages is not evaluation. And so we really need to think through how we're doing this. And there's a really important role for government to really step in and to really set the priorities and the strategies for how the technology is going to be leveraged for a broad range of stakeholders to identify what the standards, the interoperability and architectures are going to look like. And in terms of sort of looking at the design and implementation of the various programs, we need to really bring people who are the most affected by these various systems that are now being deployed into the various design processes and implementation processes from the very start. And then, as we then look toward evaluating the impact, we're definitely starting to see many, many more randomized control trials in this area to sort of assess the impact of these various technologies. It doesn't necessarily have to be a randomized control trial, but what we do really need is a greater focus on health outcomes, on the costs of these types of implementation, so that it can better inform the movement from pilots, from single focus solutions to scale and long-term sustainability. And so I will leave it at that. It will take the entire ecosystem of people working in this area to do this, whether it's government, industry, the NGO sector, the academics, to really come together, to really leverage their expertise in collaboration to build communities that need to sort of make the most effective and maximize use of mobile technology for health, particularly as we are trying to improve the health of the poorest of the poor throughout the world. Thank you very much.
Thank you. I hope she hears this. It's now my privilege to introduce Dr. Scott Campbell, the co-chairperson, Executive Director and CEO of the Foundation for the National Institute of Health at Bethesda, Maryland. Many of us have heard of the NIH, but not everybody knows that the Foundation for the NIH is an equally important organization, and we are thankful to you, sir, for coming all the way just for 48 hours. We deeply appreciate this. Dr. Campbell will be talking to us on MHealth interests and IT evolutions at the FNIH, the Foundation for NIH, and NIH. I understand that NIH has now recognized telemedicine, telehealth, and even MHealth as a major thrust area, and I'm sure Dr. Campbell will also be touching upon opportunities for India to work together with the NIH.
Thank you, Professor Ganapathy. So I'm kind of the live guy sandwiched in between the virtual presentations, so I promise you I am not an avatar. What I wanted to do was just take a few minutes, as Professor Ganapathy said, to let you know about the opportunities at the NIH. So the Foundation for the NIH is not the NIH. We are actually a separate 501c3 nonprofit organization who was basically enacted by Congress to raise private funds as well as establish public-private partnerships to benefit the NIH mission. So as such, we're basically a fundraising mechanism to leverage the federal investment in the federal dollar. So you can see what I'm going to try to do is give you a few trans-institute examples of ICT, specifically MHealth related projects that are out there. And then I'm going to focus on the Fogarty International Center, which is the global effort at the NIH, where a lot of these programs are, and then tell you a little bit more about the FNIH and one of the meetings that we run every year called the MHealth Summit. So as I indicated, hopefully all of you are familiar with the National Institutes of Health in the U.S., located in Bethesda. There are 27 different institutes and centers within the National Institutes of Health. Most of those are disease-specific centers. And MHealth and information technology grants basically span the entire scope of those 27 centers. So if you look specifically for MHealth, this is the latest that I was able to get from them. The NIH actually awarded approximately $50 million worth of MHealth grants in 2010. And as I indicated, the globally focused grants are specifically enriched in the Fogarty International Center. Roger Glass is the director of that center, who does an excellent job of being the head of that effort. And so I'll give you a few examples of that. As I indicated, the FNIH seeks private funding partners to support ICT as well as MHealth grants, and we organize a yearly summit, which I'll talk about at the end. So just to give you a few examples, obviously with grants across 27 institutes, I can't go over all of the grants, but I just wanted to give you a feel for the type of thing. So NIAID is the Allergy and Infectious Disease Institute. Tony Fauci is the director. And so here's one of the grants that's specifically involved with dengue fever, something that we're actually involved with raising money for as well. Use of cell phones and field capture and rapid transfer of data to a central dengue decision support system. The nice thing about this is it's near real-time monitoring, and this is for the capacity for mosquito vector-related data. So we actually do an awful lot of mosquito work as well. In fact, there's one project that we're doing with a grant called Vector, which was an extension of the Grand Challenges in Global Health grant that we were doing, that actually involves both the either bacterially engineering or genetically engineering mosquitoes to knock down populations and therefore to intervene and hopefully prevent spread of dengue. Now, the nice thing about this project is not only is it going to be specific and relevant to vector-borne disease like dengue, but it is certainly scalable to waterborne and foodborne diseases where data relating to vector or source contamination is routine collected in the field. So this is a method of more efficiently to do that, to get the data back in almost real time and to be able to analyze and make a difference in a short period of time. Another example, something that might be relevant to India, is EHS, is the Environmental Health, the National Institutes of Environmental Health. And so they're actually using cell phone-based time activity data for air pollutant exposure. So the interesting thing is a lot of the monitoring that's done for air pollution exposure is done at the home level. Well, that's great, but everybody usually goes out and works, and they may indeed be going into city environment to do that. So you aren't really capturing the air pollutant exposure in the city environment, only that at home. So by using the cell phone and the GPS capability within that cell phone, you can actually track the geocoordinates of that individual, and then from the monitors that are set up in the different areas, you can actually get a better idea of particulate exposure to those individuals, and therefore down the road be able to better understand how that connects to their health. There's a lot of Trans-Institute grants on smoking cessation as well. You know, that even with smoking education in the States for a long, long period of time now, there's still an issue there. Certainly throughout the rest of the developing world. And Europe, for example, there's still a lot of smoking go on. So there's a lot of things. So NIDA is actually the Drug Abuse Institute, NCI is the Cancer Institute, and FIT is the Fogarty. They all have grants in this area. A lot of them are actually targeted at young adults, which, you know, we've all heard that if you're going to change behavior, the better way to do it is when you're young or even adolescent for that matter, as opposed to when you're older. And so this is basically the fact that, you know, the young adults tend to underutilize smoking cessation services, and they have limited access to health insurance and health care usually. So smoking cessation counseling intervention can actually be delivered by text messaging, which is kind of a novel idea. And if, you know, some of the psychosocial behavioral efforts that are out there to try to affect behavior, you know that it needs a constant ping. You need to actually get on people, and you need to get on them on a regular basis, and you need to do it multiple times. Well, an relatively easy way to do that is to send a simple text message. So text messaging is certainly being used throughout the research field to try to affect human behavior. The other interesting thing, I'm not exactly the most socially networked person in the world, but most of the younger generation is anyways. Cell phones are actually being used to capture social network interactions so that you can actually determine whether or not the young adult is interacting with other smokers, what environments they're in, and hopefully then you can actually intervene and have some influence on that behavior. Just to show you this isn't U.S.-centric, there is actually some grants that are being done at the NIH that are looking at smoking cessation outside of the U.S. There's one that's being done in Turkey. This one's actually in adults as opposed to young adults. And same thing, it's using SMS text messaging to try to get the message to the environment or to those individuals in that environment to affect behavior. Now, as I said, Fogarty is the global institute, or actually it's a center at the NIH. And it has several programs I just wanted you to be aware of. So I'm not going to go into these in bloody gory detail. I will give you the email or the web addresses, I should say, that you can check. So one that's out there right now that I think is kind of unique is the Fogarty Informatics Training for Global Health, or ITGH program. This is one of the few research training programs in the world, for that matter, for informatics for research scientists in low and middle income countries. So certainly this would be something that investigators in India would be eligible to have money come from either directly or through collaborative investigators in the U.S. The whole idea is that these low and middle income countries can partner with U.S. institutions and investigators, and then this is training, and the training must address the health and informatics needs not of the collaborator in the U.S., but the collaborating countries themselves. So basically, it is the developing countries that are driving the agenda for this. Just an example of this, there's an investigator at Vanderbilt University, Cynthia Gadd, who's basically has, and I picked this one because it's specific here, informatics training partnership with the National AIDS Research Institute in Pune and the National Institute of Epidemiology in Chennai, basically utilizing their existing informatics training resources at Vanderbilt for targeted capacity building at the institutes here within India. And certainly because these institutes tend to deal with a lot of HIV, AIDS, and infectious disease, that's the emphasis for the informatics. But the intent at the end of the day is to train local experts who are able to develop local research applications or modify existing platforms to provide the tools for needs, culture, and infrastructure of their institution and country. And then you'll see the web address at the bottom for those of you who are interested in getting any more specific information on other grants around this. There's another program called Framework Programs for Global Health Signature Innovations Initiative. This one was driven by the ERA money. For those of you who don't know, that was the money that the U.S. government invested back into the enterprise. It's the basically Resource Recovery Act, Reinvestment and Recovery Act in the States. The interesting thing about that was it was a very defined time. So the ERA money put $10 billion over a 2-year time period into the NIH, but it had to be spent in that 2-year time period. And ideally, those programs were supposed to be 2 years and no longer than 2 years in length, so that they didn't extend beyond that 2-year time frame. Well, I can tell you that that money is actually coming to an end this year, and with the current NIH budget going to be cut this year, whether these programs are sustained or not, we'll see. But the FIC, the Fogarty, spent over $8 million in ERA funds to awards and supplements that involve the use of information and communication technology to improve global health delivery and research. So hopefully some of these can be sustained. Hopefully the efforts of the NIH in raising some of the money will be able to sustain those. So a few examples. One of the cool ones that was presented actually at our MHealth Summit last year is that there's been this lensless microscope developed that you can actually transmit the image through the cell phone, and you can use it to diagnose what the bacteria or whatever is, and be able to intervene and get a diagnosis and get treated a lot sooner for, these are primarily was around infectious disease. This also is involved in training fellows in global health research focused on drug-resistant infections. There are collaborating institutions in Brazil, India, and South Africa with that one. And another one that's kind of interesting, global distance learning, is something else that the Fogarty does. And there's a course that's primarily for research coordinators. These are usually nurses, but it doesn't have to be nurses at clinical sites. And once again, you can see the web address. There are a lot of training research grants out there. I'm not going to go into these specifically. These are the ones that I pulled off right now that are still actively receiving applications for them. And you can see that there's clinical research being involved there, Global Infectious Disease Independent Scientist Awards. So once again, you see the web address at the bottom. All of these, fic.nih.gov, that's the Fogarty. You can go and find all of these there. So the FIC then, the Fogarty International Center funds diverse research projects training in development of databases, informatics and bioinformatics training, distance learning, MHealth, the subject of this session, computer-based modeling, and development of basic ICT infrastructure. So these are all things that you might be able to take advantage of, either personally or collaborating with an investigator in the U.S. who have received this funding. Finally, my last slide, just a little bit of advertisement for a meeting that we run. So this will be the third year that we're doing the MHealth Summit. This is the largest event of its kind. It attracts leaders from across the global MHealth ecosystem, representing government, private sector, industry, academia, and not-for-profit organizations. The exhibitors there are expanded this year. We expect 300-plus exhibitors showcasing the latest tools, applications, and wireless technology to improve health outcomes. Last year, well, the first year, we had actually about 300 or 400 people. Last year, we had 2,500 people, and we're expecting over 3,500 people for this meeting this year. And certainly, there'll be press there as well from across the globe. It's at the Gaylord. For those of you who have been to U.S., in the D.C. area, there's a new area called National Harbor, which is kind of an area specifically for conventions. And it's going to be December 5th to 7th. I've actually placed some save-the-date cards back at the water station back there, and you'll see mhealthsummit.org is the site that you can go to get more information. So hopefully I'll see some, if not all of you, at that meeting. Love to have you there, and I'll leave it at that. So thank you very much. Should I do next one? All right, so back to the virtual reality here. Yeah, what's that? Right. Right. So we have video presentation from Pakistan right now. Who is the investigator, Dr.?
This is again a video presentation for the e-health coordinator to the government of Pakistan. Again, he sends his apologies for not being able at the last minute to come here physically. Dr. Zakiuddin Ahmed has been one of the pioneers in developing e-health in Pakistan, which, as you know, will be quite a difficult way to do it. Can we have the video, please?
Good afternoon, everyone. This is Dr. Zakiuddin Ahmed. I'm the National Coordinator for eHealth, Ministry of Health, Government of Pakistan, the focal person for WHO. I'm also the CEO of eHealth Services Private Limited and the founding member and trustee of eHealth Association of Pakistan. First of all, I would like to thank my dear friend, Dr. Ganapati, who kindly invited me to speak at this estimable conference, but due to some unforeseen developments, I couldn't be there with you myself. So thanks to technology, I am virtually with all of you there. So I hope that you will accept my regrets, and I'm thankful that you have allowed me to speak through a recorded message. the first thing which I always ask myself as well as the audience, whether we are talking about an overview of e-health in Pakistan, or we are talking about telemedicine, or anything related to e-health or healthcare for that matter, why are we gathered here? So that's the most important thing. Why have some of you, come all the way from wherever you have traveled, and everyone has gathered here in Hyderabad? For me, this is the most important question, and the answer is that we all are gathered because we want to have discussions and come up with efficient solutions to deliver healthcare to the ultimate beneficiary, which is the patient. So it's not about sitting together to discuss technology, or it's not about anything else except the patient, which we keep as the center point and the ultimate beneficiary. Pakistan, like any other developing country in the world, has many challenges, including increasing population, difficult to access terrain, uneven distribution of healthcare providers, less number of trained healthcare providers. We have a brain drain which is going on. We have the saturation of these physicians or nurses, or all the healthcare professionals in the larger cities as opposed to the rural areas. So in fact, we have around 65% of our population which does not have access to basic healthcare. Now, there is an upside that we have excellent infrastructure of IT as well as some level of brick and mortar. We have some centers and facilities which are not manned by people, but still they are there. And we have excellent infrastructure of IT which we can leverage. We all know that more than 90% of the world is now connected to cell phones, and Pakistan is no exception. Pakistan is actually ranked among the top in the usage of cell phones. We have video conferencing facilities available. We have a very ubiquitous internet availability. We have a satellite footprint. So the technology is already there, and that's why the healthcare professionals in Pakistan, we thought that we should leverage IT and the advantages of information technology, and we married health and IT together to deliver healthcare to the patients. As far as the overview of eHealth, I would like to start with the journey which we started way back in around 1998 or 99, and at that time we used to call eHealth as telemedicine, and there were not many people who were involved in that. We started creating awareness, and a few activities actually started in as early as 2000 in Pakistan. Then the Ministry of Science and Technology actually came ahead, and they formed the National Telemedicine Forum, which organized the first national conference on telemedicine in Karachi in 2002. The second conference of the National Telemedicine Forum was organized the next year in 2003, and after that telemedicine picked up momentum, and more players came up, and they had their projects on the ground. We already had the HMIS division established in the Ministry of Health even before that, which was actually connecting institutions and gathering and managing information efficiently. Pakistan delegation also participated at the SOC Telemedicine Conference in 2007 in Delhi, where all the member countries deliberated upon developing some kind of mutual projects. Then the Ministry of Health created the post of National Coordinator for the first time in 2008, where the formal planning of how awareness could be created in Pakistan on e-health and telemedicine. Subsequently, the National Council of Telemedicine and eHealth was formed, and this council became the first accepted council in the International Society of Telemedicine and eHealth. After that, we also became part of the second survey of WHO Global Observatory for eHealth in 2009, and that actually helped us to take a stock of our own various projects and activities and institutions which were involved in various applications and projects in telemedicine. Eventually, the eHealth Association of Pakistan came into being in 2009, and which actually includes nearly all of the stakeholders involved in the eHealth ecosystem, if you may, and it is the single representative association of all telemedicine and eHealth professionals and organizations. This was formed with the support of the Rockefeller Foundation, and we have had two national, actually international conferences in the last 2 years, which were very successful, not only in creating awareness, but also showcasing successful case studies and projects of various organizations, individuals, and groups which are actually working in different telemedicine areas. In Pakistan, we have nearly all the application activities covered under eHealth and telemedicine. We have the typical hub and spoke teleconsultation models. We have a big hub and spoke model in Karachi, where one center one tertiary care center is connected to 9 spokes in the rural areas. We have another hub and spoke model in Rawalpindi, and then there are a couple of more hub and spoke typical telemedicine centers which have emerged in the last so many years. We are involved in teleradiology. We have telemedicine training centers at various institutions. We have certificate as well as degree programs in eHealth and telemedicine being offered now. Pakistan was very quick in adopting the MHealth applications, and our medical call center project in Pakistan it has been one of the world's first and few successful models where it was launched with the help of one of the leading telcos, which has a very strong presence in the rural areas, and that project is being showcased in different conferences, and we were very quick in responding to the disasters, whether it was the earthquake or the floods, and essentially the state-of-the-art center at the Holy Family Hospital took lead in that, and they had a very efficient disaster response telemedicine program, which is still in place. So that's also one of the areas we were involved in. Currently, the major institutions involved in eHealth and telemedicine are, like I mentioned, Holy Family Hospital, Jinnah Postgraduate Medical Center, Aga University Hospital, ComSex, just to name a few. And there are some other companies, private companies as well, which are now involved in providing the technology and the applications and support services to enable eHealth and telemedicine to be successful. We, as any other developing country in the world, are trying to move towards the U-Health environment, if you may. And the U-Health environment is the concept of providing ubiquitous health, which means that every Pakistani will be able to access healthcare where and when it is required and at the best quality. With this objective, we are actually taking telemedicine and e-health.
Okay, that was a very dramatic end. So I think we'll...
All right, so back again, Dr. Srinivas Raghavan, a consultant for wireless health initiatives and the CEO of IUs in San Diego. I think you're going to be speaking about fetal and maternal health challenges. MHealth enables a new paradigm of care. So, Dr. Raghavan. All right, so our next to last speaker is Dr. Anand Iyer, President of COO of WellDoc. I've actually had the opportunity to visit their headquarters in Baltimore and hear a little bit about this before, having been with the American Diabetes Association before I joined the FNI, so I'm really looking forward to hear an update on this. So, Anand?
All right. Should come, huh? There you go. So good morning. Namaskaras to everybody. Thank you, Dr. Ganapathy. Thank you, Scott, distinguished panel members, distinguished audience. I'm going to be speaking briefly about what we've done in the realm of mobile diabetes management. And as you can imagine, you can extrapolate from this example to other chronic conditions. I'll quickly give you an overview of kind of where we came from, why we did this. I'll show you actually what some of the challenges are in India, specifically what the actual solution attributes should be for a solution that will actually deliver outcomes to patients, deliver outcomes to clinicians, and of course reduce healthcare costs. And finally, I'll actually show you just a little bit of the solution in action. By way of background, I'm a wireless guy. I've been in the wireless industry for 20 years, and in 2002, I developed type 2 diabetes myself. I actually use our product. I joke with people in that the two things that define my DNA, one of them is good, which is wireless in my blood. One of them is bad, is too much sugar in my blood, but here we are at WellDoc. The company was founded by myself and an endocrinologist who was really commiserating the state of diabetes management, that when you think about a patient and the complexities of managing this disease, you have to manage your medications, you have to manage your stress, you have to manage your exercise, your carbohydrate intake, smoking, sleep, all the things that affect the 360-degree, what we call picture, that is diabetes. At the same time, there was an astute observation made in one of yesterday's presentations about data, information, knowledge, and action. Even if I write down every single thing and take it into my doctor, what's my doctor going to do in a 5-minute office visit? So the human eye cannot do that kind of pattern recognition. I mean, why is it that we entrust the flying of a space shuttle to a computer? Yes, there's a human pilot as a backup, but there's too many variables to manage at once. It's no different for a diabetes patient. And so the observation was there was complexities on the patient side, there's complexities on the physician side, but the aha moment, the light bulb, was that everybody who came into the clinic, regardless of their age, regardless of their socioeconomic status, had a cell phone. And we asked the question, could the cell phone actually be part of the solution? Not to replace the doctor. When you're sick, you go see your doctor, you don't see your cell phone. Could you use the cell phone as a tool to, one, capture data and provide real-time behavioral coaching, clinical coaching at the point of consumption? So don't just use it to capture data. The second is, could you take all of the data and have a system analyze the trends, the patterns? Why is it that Anand woke up for the third time in a 10-day period hypoglycemic? Well, what was happening the night before? Let the system find out. Or why is it that every time I indicate I go outside and eat lunch at a restaurant, my after-lunch sugar is high? Maybe I need some coaching in terms of what I should do when I go out and eat, some smart, healthy food choices. The last thing is, could you take all those observations and provide it to a clinician, because clinicians don't want to get 10,000 messages a day from their patients. Could the system analyze the data and tell the physician, one, here's where they were 3 months ago, two, here's where they are today, three, this is what's changed, and four, against evidence-based medicine, this is what you ought to do. But you're the expert, do what you think is right for your patient. So the philosophy of the company is very much, it's behavior-driven, it's optimizing clinical decision support by enabling real-time access. So you all know the statistics, they've been talked about earlier, but I mean, this is a dire situation. And it's not just in India. I can say the same statistics are there for rural America. It's no different. There's inadequate infrastructure, there's limited reimbursement because people pay out of pocket for a large portion of their healthcare costs. There's certainly underinvestment in public healthcare. There's uneven access to healthcare. And then you think about a market like India where there's such a low level of diabetes awareness, just literacy. You know, the official number is 51 million or odd in India. For every one diabetes patient, there's probably 1.5 to 2.5 undiagnosed diabetes patients. So even if you're able to create a groundswell of education and awareness, you move the needle. And of course, affordability and access. So to steal a more positive line from our president, the audacity of hope. So the official number now is 791 million, TRAI as of April, right? So here is a technology that knows no socioeconomic boundaries. I mean, the rickshaw driver in Chennai who has diabetes, who has no place to sleep, has a bloody Nokia 6600 and he uses it, right? So here's a technology that's in the hands of everybody. What's amazing about this chart that you see is, in India, the highest growth rate for cellular penetration is actually in the tier 3. It's in the rural areas where they experience the highest growth today. So that's actually encouraging. It's not just for the richest of the rich, it's actually making its way quite strongly into the rural villages. So when you add wireless and clinical know-how together, what do you actually get? So when you look at this chart here, frequency of clinical intervention on the bottom and the intensity of the intervention, you'll see surgery in the upper left. That means I hopefully don't do surgery too often, but when it happens, it's actually a major event. Versus the diametrically opposite quadrant has chronic pain, which I manage on a daily basis. I may pop some Advils or some Tylenols. The problem in our healthcare system, really globally today, is that upper left quadrant. All these chronic diseases, diabetes, hypertension, asthma, COPD, these are not managed on a high-frequency basis. So what happens? People end up in acute situations. They end up in the emergency room. They end up being admitted to the hospital. What wireless does is it takes that cost basis and it shifts it down. So we've effectively removed high cost by actually empowering patients to do the things that they need to do. Think of it. There's 8,760 hours in the year. And if I see my doctor 4 times for 15-minute office visits, what am I going to do the rest of the 87, 59 hours in the year? I need to manage myself. So we talked about data, information, and knowledge. I'll just build this, but think about what we're doing with mobility. We started in the lower quadrant. In fact, all we had was quarterly lab data. That's all a doctor would go by. And you know, an A1C, and I'll explain that in a second, an A1C number can show something, but it actually doesn't show the variability of what's happening on a day-to-day with the patient. If I can take that data and actually capture, if you would, high-frequency data and multivariate data, what they ate, when they took their medications, how much medication they took, I can actually affect positive outcomes. So what's the solution? The solution is 4 things. 1, it's a patient coach. That's software that's delivered to a patient's cell phone that gives them their testing reminders, coaching reminders, medication reminders, actual clinical algorithms on how to correct their blood sugars. So for example, if their sugar is high, how do you bring it down? If it's low, how do you bring it up? And of course, how I bring my low sugar up based on my medication and my medical history may be different than somebody else. So this is personalized to that person's medical history and their condition. I'll show you how that's done. There's this automated expert system, which is really the cloud. How do you look at all these longitudinal patterns? There's clinical decision support. This has to be integrated into clinical workflow. Our objective is to bring the patient and the provider closer together. And of course, there's the nurse portals, the call centers. Charles and I were talking that when you think about India, a really, really good model is how do you empower a call center to have greater visibility into what's happening with the patient so that that nurse can actually help the patient deal with what they need to be dealt with, and that nurse doesn't waste his or her time on a patient that doesn't need help. How do you do it? You do it using the technologies people already have. And don't force them to buy an iPhone. Don't force them to buy an Android. Let it work on a J2ME phone. Let it work on a Brew phone. Let it work on a smartphone, dumb phone, whatever phone, right? In fact, let it work on a PC. We're putting this into vehicles so you can access this directly from the vehicle. Let people access this from the technology and the platform that they want to use at that point. Be agnostic to that. So here's some illustrative. You see some screens in terms of how to capture blood glucose, in terms of a logbook function, in terms of actual feedback, in terms of carbs and medications, actual algorithms to help the patient along the way, illustrating, and I'll show you a real transaction. To talk about outcomes, this is very important. So in diabetes, as many people know, the primary marker of diabetes wellness is A1C, which is Simply put, the amount of sugar in a patient's blood. So the target recommended by the American Diabetes Association, and that too globally, is 7%, which means 7% of your total blood volume is sugar. Now, the importance of that number is as follows. Every 1 point delta, 7 to 8, 8 to 9, represents a 42% increase in the risk of heart attacks, strokes, kidney failure, blindness, amputations, all the negative things that diabetes causes. Just out of curiosity, today in the U.S., for the 27 million people who have diabetes, the average A1C is 9.3. So just imagine how broken the system is. When a drug is introduced, the FDA heralds the drug if it drops A1C by a half a point. So when Merck launched Januvia, it's a $4.5 billion drug. It dropped A1C by 0.7 of a point. Don't get me wrong, it's a great drug. I take it myself, I'm on it. But a 2-point reduction is unheard of. So if you can actually take this coaching, augment a patient's insulin therapy, medication therapy, you start to get these kinds of clinically validated, these are now published in clinical journals, these are real tangible outcomes. When you think of blindness and you think of amputations in India, we can avoid these things. We can use these things for preventive care and we can make a huge, huge societal impact. This is a study we did at George Washington University with Richard Katz, head of cardiology. Look at the difference in people's self-care. People who, against blood sugar, blood pressure, lipids, their foot exams, eye exams, dental exams, look at the improvement in their own performance. By the way, this study was conducted with the Medicaid population in Washington, D.C., and specifically homeless people. So we're not talking about white-collar, BlackBerry junkies, techno-sophisticated. This is the person who doesn't have a place to sleep. And this is what the improvement in their quality of life was and the quality of their metabolic measurements. Look at this statistic in terms of the number of reduced hospitalizations. This is where you knock out cost of the system. This is an amazing statistic. If it works for people like that, it's going to work for everybody. So, last slide, and then I'll show you just a quick overview. 4 critical success factors in this. You have to have outcomes. You all saw the FDA release from last week. They're looking for 2 things. They're looking for outcomes, and they're looking that you actually work and innovate within the confines of what the regulatory policies are. People here say, you know what, I don't care about the FDA. I've had conversations with hospitals and health plans here, and they're all, this is wonderful. And then they ask, by the way, is this FDA cleared? So, right, wrong, or indifferent, they still look at the FDA as it's a means of ensuring patient safety. Everything that you guys talked about for the last 2 days. So, outcomes, you have to show improvements in health, tangible, that clinicians believe, that clinical community believes. Regulatory compliance, it has to be accessible. And accessibility isn't just technology platform, it has to be socioeconomically accessible. Hey, this is an OpEx model. Everybody already has a cell phone. I'm not asking for millions of dollars of EMR infrastructure. Hey, there's 3 letters you should know in the English language, OPM, other people's money. Courtesy of Tata and Airtel and Aircel. These guys are building out an infrastructure. We should piggyback on top of that. Okay? There's no need to create a parallel universe. And of course, the last thing is integration. So if I just show you kind of quickly how a patient registers. Registration can be done online. Registration can be done telephonically with the nurse in a call center. And you see we gather the basic information, their name, their address, their demographic information. We capture their medical history. When they actually capture the medical history, they're configuring the software for themselves. It's a personalized application. We capture when they eat, when they exercise, the level of intensity, so the phone reminds them to do these things. Once that's done, they actually get the software. And I'm showing this to you on an old J2ME phone because, as somebody pointed out earlier, of the 791 million cell phones in India, this is still the vast majority, so it's got to work on this platform. But for example, if I make an entry and I actually put in a low blood glucose value of, say, 58 milligrams per deciliter, you'll see right away that the phone will tell me that it's, is it low? Yes. It'll tell me how to correct it, actually show me this 15-15 rule that I walked through. Here's examples of 15 grams of carbohydrates, and I can change this. I can change this to say have 2 Sabati sweet packets if that makes sense here. So the phone actually guides the patient through, and of course the last thing is the portal for the nurse or the doctor. Oops, I hit the wrong button. They have access to the patient's full spectrum of all their readings, their logbook. They can see what's happened. They have a dashboard. They can slice, dice. So what you've done is you've brought the provider and the patient closer together. So in closing, this is something that we think can massively disrupt healthcare as we know it. Everybody has this technology. Everybody has access to this technology. Let us figure out collectively. We need wireless operators. We need hospitals. We need health plans. You know, we need physicians. We need the entire ecosystem, but we have an answer. We're looking forward to working with you. Thank you.
All right, so our last speaker of this session, we're pretty close on time. We're just a little bit behind, but is Charles Anthony, CEO of HealthNet Global, and he's going to be talking about healthcare, IT, and telecom, where they converge in MHealth. So,
okay, thank you. How do you play it? Good afternoon. So let me start a little bit about MHealth in India. Even though it's a global story. And the couple of things I'll cover today is what is MHealth and what is the research that's been done. But most importantly, it's all about implementation. It's all about business model. Is there something we talk about researching and trying to get solution out there, or is it about making it a business out of it? So I'll cover how do you make this into a business opportunity for all of us. So the vision that we have is touching billion lives. So how do you go about touching billion lives using MHealth? If you look at the current situation, not only in India and also throughout the globe, the supply and demand is a huge issue, and is an issue that's not going to get solved in a near future. And the reach is another big issue, especially in India with all the rural, and that's why we opted to go after mobile healthcare, where we could have at least access to rural with reach. And uneven distribution. We have lots of doctors and medical professions in urban area, and we hardly find anybody who wants to go to the rural area. These are the challenges facing at least currently in India right now. And if you look at the ratio of per 1,000 patients to our doctors and to a nurse, if you take the yellow line, that's the doctors, and the orange line is nurses. Right now it's about 1.25 doctors per 1,000 and 2.5 nurses per 1,000 people. If you look at the India side, you will see India will reach that number sometimes the year 2022. So even if you build hospitals, even if you open universities, you will, by the time you get there to the global standard of healthcare professional, it will be year 2022. So we have a problem. And how do you solve the problem? And we believe you're going to go after the MHealth. In the same time period in India, the market drivers are changing. The population is growing. The lifestyle diseases like obesity, hypertension, all those are beginning to add up to the list. And insurance companies are entering Indian market. So there is a paradigm shift in Indian landscape. So there is a lot of dynamics here, and a lot of things are changing at the ground level as we keep talking about MHealth. And if you look at the Indian system here, there is a jigsaw of high cost of healthcare, urban-rural divide, lack of last-mile access, individual silos, awareness, standards, patient safety. There's all kinds of issue. Is this conference here is going to solve all the problem? The answer is no. So what little we could do is what we'll discuss today using MHealth. If you look at the other side of the equation, there's a lots of money being driven. There are about 200,000 crores that India is going to invest on healthcare. So about 2 to 3% of Indian GDP is going to go towards healthcare. So there's a lot of money available there in spite of a lot of opportunities and challenges. In India, about every 1 rupee, only 16 paise goes to the real person in the rural area. Other 84% get lost along the way. So there's a real problem, even though there's a lot of fund, how does the real fund get to the real people? And if you look at the Indian landscape, we keep talking about rural India most of the time, and we keep talking about urban. But the real opportunity and real need is in the tier 2 and tier 3 cities. The cities which are what in India they define as tier 2 and tier 3, that is where we see as an opportunity, that's where we see a growth. A lot of people in rurals are migrating towards the tier 2 and tier 3 cities. A lot of people urban are moving towards tier 2, tier 3 cities. So that is the opportunity area for us to go after. If you look at what we have to do, we came with a concept in our company called pull from the future. Do not copy anybody. Technology is available, whether you are in US or in UK or in Russia. At this point in time, technology is irrelevant. It's transparent, the world is flat, information flows fast. So it is not about going to US and trying to get some technology. The technology is available to anybody. And we could create technology anywhere you want these days. So the real issue is not about technology. The real issue is about implementation and making a business model out of it. So we came with a concept called healthcare, IT, telecom convergence. There are people like me who's been in telecom for over 30 years. We know what telecom is all about. We ran IT companies. So we thought we should come with a convergence called healthcare, telecom, IT convergence, which creates a digital healthcare. And digital healthcare could reach billions of people much faster than the brick and mortar approach. So we create a roadmap. The roadmap goes anywhere from, we will help you do it yourself. You give us a call, we'll tell you how to do it. You give us a call 24/7, we'll guide you and coach you and mentor you. The next level in our roadmap is, we're going to let you do it yourself. That is what basically Anand was talking about Velda. And we are not quite there yet, but that is the next evolution in India. We're going to let you do it yourself. And the third one is remote monitoring, where we could watch people in the rural India of remote. At this point in time in India, the 3G has been launched. The time is right, the technology is right, and people are very hungry about downloads. If you look at 42% of US telecom operators' revenue are from downloads. If you look at India operators, it's about 13% of their revenues are from downloads. So India will get to 30-35% of downloads in the next couple of years. So it's a download-hungry environment at this point in time. If you look at the last graph in the bottom right-hand corner, the subscriber base in India is about 600 million and is growing. And it's about 63% penetration. It's about 89-90% urban. It's about 14 to 18% in rural. But if you look at the ARPU, the revenue is almost 2 cents. And it's almost one of the lowest ARPU in the world. So here is a paradigm shift. You have a huge amount of volume, you have a huge amount of subscribers, but the amount of revenue, the amount of ARPU they pay is one of the lowest in the world. So how do you take advantage of the situation and create a business case out of it? So we designed a solution. The one thing I'll talk today is not about the dreams, not about the research. I will talk about real terms, real thing, what's really going on in India and what we have really done there. And we have solutions anywhere from 2G all the way up to 3G. Whether it's the call centers, we call them medical response center, or it's the downloads, or the 3G teleconsulting. The 3G teleconsulting will be launched next week in India, pan-India. The downloads are available right now. We have about 500 downloads on the healthcare, and we already have 2 centers which actually have 24/7 manned by doctors, nurses, paramedics, physical therapists available to Indian community. We have picked up partners like Qualcomm, Cisco, British Medical Journal, Clinical Solutions, and Apollo. So we have brought in the best of the best as a partners into India so that we could deliver the best of the solution to the Indian community along with our technology. What is the access layer for the people in India? They could access our solution through mobiles, to internet, kiosks, and we also want to get into IPTV. We want to get to the home. We have intelligent TVs in India. We want to get to the TV. We will focus on pregnant women, infants, youth, adults, elderly. This will be our focus area in India. And we'll bring the ecosystem of doctors, nurses, hospital, labs, pharmacies, and insurance. The difference is not about delivering a standalone system. It's providing end-to-end ecosystem. That means you bring the subscriber on board, you bring technology on board, and you build yourself around the entire ecosystem. Right now we have about 52 hospitals, about 1,300 pharmacies, about 65 clinics, about 7,000 doctors in our ecosystem. So not only the people could actually get the help through call center or through the mobile download, they actually seek out and use any one of the ecosystem that we build around it. It took us about 6 months to do that, but right now it's up and it's working. So our solution covers, like I mentioned before, from pregnancy to all the way to the old age. We created a network here which covers patients, doctors, nurses, hospitals, labs, insurance, and pharmacies. So everything is integrated. So if you call a number, in this particular case, let's say Aircel, if you call 55104, not only you get a doctor attend your phone call 24/7, they could connect to ambulance or pharmacy or doctor appointment, all 24/7. In middle of all those, we created our so-called cloud. We call it HealthNet Global Cloud. And if you look at the cloud, we have a call center. And what the call center does is, if you look at it, it's got doctors and nurses, and you could take a mobile phone and call a 5-digit number. It will go to the doctors, nurses, and it will give you advice any given time. These advice are driven by in a triage based, and it is well-driven triage. It's not something we developed in one day. This was developed by Clinical Solution. It's rolled out to NHS. It has got about 60 million transactions, been there for 8 years. So one of the best solutions we brought to India as exclusive partners. We went and picked British Medical Journal. They've been in the business for a long time. So you bring them on board. We have created a call center which has got the entire state of the technology of call center in 2 centers. And we also brought in all the redundancy here. How do you put this? So we have created all those things. Now what we have done was not only create a technology, we actually rolled out. We rolled out to entire pan-India. At this point in time, we have about 130 million subscribers who actually use our solution that I was talking about. Our goal is to reach this year by 330 subscribers. That means we'll be the largest healthcare wireless integrator in the world. And that is our goal, and we are halfway there. Our goal is to get to 300 million subscribers. If you look at in the last 3 months, we have launched the system. At this point in time, we have taken about over 200,000 subscribers who are called our call centers. So every day we get huge amount of calls coming into our call centers. And the people call for is respiratory problem, orthopedic problem, GA problem, weight management. And these are reasons that people call for us and we give them advice. The typical age group is anywhere from 21 to 40. That's typically our age group with people who call us. And so this is our vision. Our vision is not just create a technology, but create something which is operational, which could be implementable, and which have a business model. So that's basically what we have done so far. You want the video? We will run a small video which is only about 2 minutes long. That gives an idea of what this so-called call center really does in India.
Apollo Mobile Healthcare Service aims at delivering consistent, high-quality healthcare to ASL subscribers anytime, anywhere. This service is backed by qualified medical professionals and doctors from Apollo, supported by a world-renowned tried solution. From the comfort of their homes, subscribers can now call and talk to Apollo Health Advisors for a consultation on life's little urgencies like allergies, fever, infections, injuries, or your baby's health problems. In this audiovisual, we will demonstrate how this service was very useful to a family at even the oddest of hours. It's past midnight. The mother is tensed about her 1-year-old baby, constantly crying and breathing heavily. Let's see what happens further.
What are you looking for?
There was a diary here.
It must be there.
I had the doctor's number in it. I kept it here somewhere only.
Can you just call the number that Jaya gave me? ASL Apollo Mobile Healthcare. Can you
Is it
just
here?
try that number?
Which one? This one?
Yeah, this one.
Hello? You just talk.
Yeah. Hello?
Greetings, ASL Apollo Mobile Healthcare. How may I help you?
Yeah, my child has been crying for last
1 hour. She seems to be in a lot of pain and restless.
Don't worry, we'll help you out.
I'll need a few details.
Thank you so much, doctor.
Could you please give me your child's name, age?
Anyway,
Mahalakshmi Shankar.
1 year, 10 kgs. Well, thanks for that.
Now I'll need you to answer a few questions for me.
Sure.
Does it look like Lakshmi has difficulty breathing?
Yes, she's finding it a bit difficult.
Is her breathing sound getting more prominent in the last hour?
Has been the same.
Mild but audible.
Is it her first time with the present symptoms?
No, doctor. She never had this.
Problem earlier.
Does Lakshmi have any dusky or bluish discoloration of her lips?
No, not at all.
And has there been any episodes of vomiting?
No.
And does Lakshmi look tired when she's breathing, or does she have fever?
No.
Is she getting drowsy?
No.
Right, let me reassure you.
There's nothing to worry about. And from the symptoms that you've shared with us,
I think Lakshmi is having an asthmatic tendency.
don't get anxious. We shall help you out in the best possible way.
All right, doctor.
There are a few instructions that I would need you to follow now.
Okay.
I need you to ensure.
Lakshmi is loosened off any restrictive clothing that she is wearing.
Okay.
Now make sure that she
Stands up to allow full expansion of her lungs.
Right.
This will facilitate her to breathe better.
Okay.
Please ensure that no strong odors or perfumes are sprayed.
Okay.
If possible, please encourage Lakshmi to have some warm, clear liquid.
Right, doctor.
Right, and if she does develop fever, she might be going through some sort of a possible
Chest infection.
Okay.
Ma'am, can I dispatch some medications to your residence with the help of our pharmacist?
I really need that, doctor, please.
We will dispatch a meter dose inhaler with salbutamol and a spacer to your place. And you need to ensure that Lakshmi is administered at least 2 to 3 puffs.
Okay.
This will relieve her of her symptoms, and please repeat this after 20 minutes if the symptoms persist.
Okay.
This will definitely help.
Right.
The asthmatic tendency should settle down after you administer this medication to Lakshmi, and she should get better. But I still suggest that you get Lakshmi evaluated by an Apollo child specialist.
Anything else that I can do for you?
No, doctor. This has been great.
The medication shall be delivered to you promptly, and you should receive a confirmation SMS.
Yes, that would be great, doctor.
If you think that Lakshmi is getting more irritable or drowsy, or if you think that her symptoms are getting worse, then please do not hesitate to call us back. We will be happy to help you.
I surely do.
Thank you for calling ASL
Apollo Mobile Healthcare.
Wishing your daughter a very speedy recovery.
Thank you.
This solution has been widely used in UK, Norway, Spain, Portugal, US, Australia, and in many other countries. It is the only one in the world to be adopted for a nationwide launch. This has been developed by our global bench of highly qualified doctors and has been successfully delivered to over 100 million patients encountered in the last 8 years. Today, it provides active services to 15 million patients each year.
Yeah, thank you. This is a service we launched about 3 months ago. So far we got about 200,000 calls, and we'll be launching IDEA next month. That will also be rolled out in Pan India. Thank you.
All right, in order to give you at least 30 minutes for lunch, we're going to take 5 minutes maximum if there's any questions. So if we could have the lights in the audience so we could see, please. There you are. I see a question straight ahead there. Can somebody take a mic over? And then I see one over here, too.
Hello, this is for all the speakers. If the MHealth framework generates a wrong diagnosis or a wrong report or an analysis, it's open to be sued. How do you handle this?
I think the question was if the MHealth analysis is a wrong diagnosis, how do you handle that? That was the question? Yeah. Okay. That was for all. Anybody want to take that one?
I'll make a quick comment on an implementation similar to the one we just saw in the video that's happening in Mexico. It's called Medical Home. And my understanding from the people that manage that particular system is that they're able to resolve 60% of all phone calls over the phone in the way that you saw on the video. And then the other 40%, they are careful to refer to doctors right away. So the phone system seems to be a great way of sort of avoiding unnecessary visits to the doctor, but then of course referrals to the doctor or asking them to go to visit the hospital is done when necessary. So it's a great way of sort of alleviating overall burden of visits.
Oh, this is Sri Hari. This is a question for Dr. Anand. You touched on the diabetes, which is, people say it's not pandemic, endemic, but more like a tsunami, especially in Indian population. And also you brought about that, diabetes control can be like a stitch in time saves 9, other complication. But I still, you have got a wonderful solution, but how do you roll it out at a business model? Because I've been talking with the healthcare professionals. Should there be a parallel organization by, not MBBS kind of guys to take at least secondary, tertiary prevention to be effective? Otherwise, the economic burden is to be very high.
Yeah, it's a great question. I think there's several business models that come to mind. So let me share with you at least what we're doing and then what we envision doing in emergent economies such as India. First, in the United States, we don't sell directly to the consumer. We sell to the health insurance company. A 2-point A1C reduction in our trials has been shown to save, measured, $1,530 per patient per year in actual cost savings. So the health insurance company has said, give us a price. Give us a monthly license. Include the airtime if you want to include the airtime of the device, whatever. It's about a 6 to 8x ROI for them. So business model number one is the health insurance company pays for it, and they make it available to either self-insured employers who pay as part of their employee care, or it's to individuals who subscribe to health insurance. The second model that we're pursuing is we believe these are only as good as your doctor is involved. In fact, in our clinical trial, we had several arms of our study, in our randomized control study. One of the arms had a patient-only solution. Okay? So the patient got well doc, doctor got nothing. If the patient wanted to print, they could take it to the doctor. In the next arm, the patient got well doc, but the doctor only got access to the raw data. They didn't get any of our expert analytics that came from the system with recommendations. And in the third arm, the doctor got everything, patient got everything. Even though there was improvements in all three arms, the best improvement was in the last one where the doctor got everything too. So we're now approaching CMS, the Centers for Medicaid Services, and we're looking for a reimbursement code. That means a doctor can prescribe WellDoc and they can bill for it. So doctors told us three things. They said, one, we love it because it's making our patients better. So there's some altruistic reason they went into medicine. Two, you guys are doing the dirty work for us because we don't have the time to say, hey, bring in your logbook. Hey, what did you do this? They can't bill for that. And the third thing they said, obviously, is if we can make some money, if we can bill, say, $50 or $48 or whatever a CPT code is. So that's another business model we see. And of course, the third business model is not an enterprise one, it's direct to consumer. One thing we may consider here and elsewhere with wireless operators, I mean, think about it. My father is diabetic. Would I pay 200 or 300 bucks a month to manage him? Absolutely I would. I'd get him a subscription, right? And I would be the second subscriber to that. So I think it isn't a one-size-fits-all. There's going to be different business models that will work for different patient types, groups, geographies, etc.
How about rural India? No insurance coverage. How about rural India?
So I'll pass that on to Charles, but here's my one thought, because I don't think I know enough to answer that question. One thing I would think about is the same way we're doing pilots with the state of Maryland, with the state of Texas, with the state of Alabama. These are rural states, so the state is providing this as a service, right? In the case of the state of Maryland, they have to take $1.8 billion in 2011 out of healthcare costs. That's the target. These are things that can actually help remove that. So would you pay $1 to remove $6 from the equation, which is the mentality? I think there could be a parallel here where it's offered, if you would, by the state or by the country, but I don't know if you guys have a different perspective.
Yeah, I think the business model in India, it's a really tough one. I think the technology is the easiest part. Content is not that hard these days. Creating a business model is the real game now, right? And if you look at India, especially, where it's a very price-sensitive market, nobody wants to pay it, and it's a very high volume. So who pays for it? That's the question. If you could bring the advertisers, people who advertise on the mobile phone, you do the video streaming with the sponsors, if you create lead generation for the insurance companies. So it has to be people who are not the real consumer. The consumer will not pay in India. And it has to come from a sponsor, advertisers, those kind of people, or from the government. And government things just don't move in India anyway. So the business model in India is completely different, and I don't think it's going to be any different in US either. The end user is not going to pay. Somebody got to pay it. It's very similar to any TVs. We all watch TV, the commercials pay for the shows. This is evolved into that model sooner or later, and whoever figures out the silver bullet, you got the good business going.
Building off of what Charles said, one more answer. The pharmaceutical companies, so we work with pharma as one of our target segments. In every one of our clinical trials, the medication consumed by the patient against what their doctor has asked them to do has increased dramatically. So doesn't matter what the disease is, doesn't matter what the drug is, they measure these things called persistence and compliance. How many after the 6th refill, what percentage are taking, and after the 12th refill, what are the percentage are taking? And all the curves look like this, okay? We've seen these curves dramatically come up. And for the pharmaceutical company, its area underneath the curve is revenue, right? So they're saying now, hey, can we co-brand, can we sponsor, brought to you by blah, blah, blah. It's a double-edged sword, though, because there's a trust factor. Oh, is this a black Trojan horse from the pharmaceutical company? I think we still need to figure out those details.
Is there a last question for me?
Yeah, and make it a quick one, please. And then anybody else has questions, come up and see us after.
This Sampak Kumar from Shankar Netharalaya. This is a question to the last video, presenter of the last video on MHealth, AirCell part. There is definitely a subjectivity in the kind of responses which the patient or patient mother gives. Will it lead to some kind of ambiguity in the prescription that is given? What I want to know is whether those data that has been given, the 200,000 MHealth interactions, are they analyzed later and found what kind of correctness is there, or probably like that?
Yeah, good. First of all, we do not prescribe any medication. We only do over the counter. Second, we always recommend, if you watch the video, within next 24 hours, go see a doctor. This is not replacing a doctor. This is just an emergency situation that we could avoid middle of the night, like you saw in the asthma patient. And third thing, we have a clinical governance of the senior most doctors, about 8 of them. Every one of the calls get analyzed. All the calls are video logged and audio logged, and we go through every single call and do the quality analysis. The software which drives is just not written by few of us. It is written by 37 some doctors for last 8-9 years. It is used NHS for about 8-9 years. So these are very strongly driven protocol-based software designed for long time and well researched. Again, there is no OTC, and we'll never ever tell them in a call center, this is a replacement for a doctor. So it is a quick fix. If you have quick burn, you have asthma, you have upset stomach, and I think the whole idea is you go to emergency room only when you have to. Can I avoid it? Yes, we could. When we see in the triaging, if it's an emergency, immediately we dispatch an ambulance. We don't push the system beyond that. So I think that's what India needs. The business model is evolving. It's quite tough. How are you going to bring this into a real life business model? So time will tell us how we're going to go about doing that.
All right, with that, I think we'll end this session. Thank you all for staying and being interactive, and I believe it's lunch now. There'll be a few announcements.
Ladies and gentlemen, that was the session. For any more questions, you can definitely ask the panelists during the lunchtime which will follow. But for now, may I please request our chairperson to give away the mementos to the panel of speakers. Can we have the mementos, please? And I also request Mr. David K. Elwood, the Senior Executive, Global Health and Technology, USA, to please come up on the dais and give away the mementos to our chairpersons of this session. Can we have a round of applause, everyone? Also a reminder that the entire conference is being webcasted live by Medversity Online Limited, which is the first medical e-learning venture of Apollo Group. And the archives of this event will be placed on www.medversity.com website. It's also available for free viewing. Please explore that.